Good evening, everybody. Welcome back to Harmon Speaks. We have an old friend revisiting this night. He was here about a year ago. This is Michael Yates. We actually are friends. I say that for every guest, but I actually like this man. And Michael, tell me a little bit about what you do, buddy.
Sure. First, Gary, I'm happy to be back. I'm sporting my mental health awareness shirt.
Yeah, we got to put this on the picture at the beginning. This is a great shirt. All right, go ahead, man.
So I am Director of Development at Ridgeview Behavioral Health, which is a community mental health center located in, the main center is located in Oak Ridge, but we serve Anderson, Roane, Campbell, Morgan, and Scott counties primarily. There's some other rural counties we also serve. And Director of Development is a fancy title that means you wear lots of different hats. Depending on the season and the time of the year, but you're really not a master of any one discipline. So
it's a job you can have without knowing anything.
That's right. That's right.
That's not true. Well, anyway, I really appreciate you being here. And if you don't know, this is Mental Health Awareness Month, so thank you for wearing a shirt with the theme. I'm afraid business is probably pretty good. Is that right?
Yeah, we've got the double whammy where not only has the pandemic impact, but just all the challenges that life is presenting with other things going on in the world. And combined with a workforce shortage in healthcare. Behavioral healthcare is not immune to it. It means that, the demand for the service is great, but the supply of clinicians to meet that demand is it's pretty low.
I can only imagine. Well, what sort of, I know we're going to focus in a little bit about suicide prevention, but before we get there, what types of problems are you running into these days?
A little bit of everything. I think the key ones are certainly related to substance use. That has gone up tremendously. So we see a huge increase in anxiety and depression with mental health conditions, and then with substance use disorders, an enormous increase in illicit fentanyl, opiate, synthetic opiates. So the drug overdoses are higher than ever. We hit a new milestone. There was a 30% increase in the last data that came out. Tennessee has had its highest overdose death rates, primarily due to fentanyl, which is now it's being found in all kinds of products, laced with everything from marijuana to copycat Xanax pills to you name it. And it's incredibly dangerous because of the potency of the synthetic types of opiates. It's so much more dangerous than heroin. Which, when we grew up, you talk about heroin, it's like, whoa!
We're scared to death of it, Well, the movie said we were going to see really scary things in the mirror. So, so I never did it. I was afraid. I see a scary enough thing in the mirror, so I couldn't do it worse. But, I'm sorry to hear that's going up. Not surprised, but so they put it in a lot of other drugs just to get you hooked into it, right? Wow.
And the supply, or even earlier today, I was listening to a webinar from the writer of The Least of Us, Sam Quinones. And his book is about the opiate epidemic, but in particular the latest uptick of methamphetamine and fentanyl, because there have been mechanisms put in place to clamp down on prescription opiates like oxycodone, oxycontin, that kind of stuff. But as a result, these other drugs are coming roaring back because the supply, the abundant supply of them, it's cheap to make, it's easy to make. You don't have to worry about seasonal growing times for poppy seeds, or they can just make it year round.
Wow, that's incredible. Well, I thought tonight we should talk a little bit about suicide prevention. It's a topic that's near and dear to my family, and unfortunately continues to be a problem nationwide. Tell me what suicide attempt rates look like these days.
Yeah. Well, like you, it's near and dear to me, not just professionally, but personally as well.
Right.
I've lost 4 people that I was from college, a roommate of mine, all the way through to most recently, about a year ago, a childhood friend. They were all self-inflicted gunshot.
Wow.
And so, it is, though, during a time like Mental Health Awareness, it's supposed to be sort of an uplifting message, the hard, real truth of talking about the impact of suicide.
Right.
Not just about preventing suicide, but on the rippling, collateral damage and impact it has on friends and family is it's untold. Right.
If they understood that damage more, would it slow it down, do you think? Maybe not.
It's a great question. I wish I knew the answer to it.
Yeah.
What I keep coming back to is William Styron, the author of Sophie's Choice. Right. He has this wonderful memoir, Darkness Visible, and it's about his own experience with a major depressive episode that resulted in numerous psychiatric hospitalizations. Mm-hmm. And the way he framed the type of despair that is beyond despair, that unless you've experienced it in its most extreme mode, no one can really fathom. So the thinking is, well, if we can just help them understand, well, the collateral damage is really severe. You know what you're doing. The concept is they're in such pain and anguish and despair, that kind of rational point of reference, it may work for some, but not for everybody.
Not for everybody, right. Okay.
Now, an interesting stat that I found, 'cause I'm still a little surprised by it. We don't have all the latest information. Coroners have to do their thing, turn in the data. But what was interesting was they suspect that there's been less adult suicides during the pandemic. However, the increase in 18 to 24-year-olds has gone up tremendously, with almost a quarter of those in that age range having seriously considered suicide. So we've got that demographic that's thinking about it, considering it, acting on it. But the adults now, just as we just talked about the impact of substance use leading to overdose deaths, it's so I'll be interested to know in a year or two after they kind of suss that information out. What do we really know?
Okay. But let me ask you this. I know you said the 18 to how old?
24.
To 24, okay. How many of deaths of that age, or what percentage of deaths of that age are suicide compared to accidents or whatever?
Well, it's a great question. The latest we had from the Tennessee Suicide Prevention Network, which collects the data across Tennessee, it is the second leading cause of death for that age range. Now, number one is what they call accidental injury. So, that could be everything from, your auto accident to, jumping off the bridge to do a gainer, with a couple cans of courage in your
That's a dumb idea. Don't do it.
It's not. We're not recommending that.
No. Okay. And I have known some examples of people having auto accidents that were intentional. So
yes. Well, that too. And I know enough to be dangerous on this part where, part of the determination of cause of death. it is entrusted to the coroner to make that determination.
Right.
Now, in some small rural counties, the coroner knows the family. The coroner knows the minister. The coroner knows, and out of abundance of care and compassion for,
you don't want to say
it's like, yes, the cause of death was the telephone pole.
Right.
That
you ran into.
So,
and you don't want to say that it could have been suicide, right?
And so, yes, in the very least, the numbers are probably much higher than what is reported.
Right. Okay. Well, let's talk about some of the myths surrounding suicide. I know one of the things that I learned from you is that you always take talk of suicide seriously. And that saves someone I love very much. And I appreciate that because I'm a bit cynical. And when I hear that, oh, come on, you're not going to do that. And I dismiss it as my initial. Talk to me about why that's wrong. Why I'm wrong doing that.
Well, I mean, you and I come from a same period of time, and how I would have responded to my college roommate talking about being suicidal, I would have said all the things that you shouldn't have said. You're not going to do something stupid, are you? Now that you're not going to be so self-centered as to do it that way, are you? And I would have thought it was funny that surely
he's not going to do it.
But we know now that for a lot of people in such severe pain and anguish, when they're talking about or intimating suicide, any reference of it is a portal to actually get it out and to talk about it. So that is one of the other myths, is that if I talk about suicide, somehow I'm going to plant the idea in your head and you're going to act on it. When actually just the opposite is true. People are more inclined to have a measure of relief, like it's no longer, oh, thank God, yes, I feel horrible. I'm miserable all the time. Please, let's talk about it. I'm glad it's not a secret anymore. There are times when I go to sleep and I wish I wouldn't wake up. Those are avenues to talk about what is a subject matter that for years has had so much stigma and shame associated with it.
What other behaviors give you the indication that someone is considering suicide?
Good question. So it can be a combination of things. One of the things we try to do with our suicide prevention class is help people not kind of do a constellation of things that you listen for that people may say, behaviors that you may witness in what people do. So one would be putting your life stuff in order, beginning to bequeath stuff to people. An increase in substance use, hoarding of medication, of pills, beginning to acquire guns when you're not really a gun fanatic. Those kinds of things, prolonged isolation, depression for an extended period of time, no enjoyment in activities that you once enjoyed, resistance to socialize in the ways that you once did. And then there are situational cues, things that you're listening for things, you're watching for things, and then you're also aware of other things going on in people's life. Like, I lost my job. If you're a child, maybe you've had to go through an unwanted move. You've got your core group of friends, and now you're uprooting me and moving me elsewhere. Great. Thanks. A recent diagnosis of a terminal illness. Certainly for the elderly, that's a big one. I don't want to be a burden to the family. So there's a lot of different. I think the real lesson is to try to just be observant. Pay attention to what's happening in your friends' lives, your family's life, and be cognizant to kind of, don't be afraid to put some of those dots together. What you hear them say, behaviors that you observe, and situational things going on in their life.
When do you know that you're beginning, the difference between beginning to notice that some of these things are beginning to happen, and when you get to the point where you go, now I need help?
Yeah.
When do you get to that border?
I think it begins with just after you've made that discernment. I'm really worried about Joe.
Right.
I'm beginning to get scared about what Joe's thinking.
Right.
Is then asking the question. I need to ask Joe if he's thinking about hurting himself or ending his life.
Right.
And that's one of the beauties of some of the evidence-based suicide prevention training, is that it equips you with how to ask the question, and there are direct ways to ask it and indirect ways to do it. And to thine own self be true.
Right.
You need to be authentic. I always tell people, look, this is what the curriculum says.
Right.
But how would you do it? That is authentic and genuine and sincere from you to the person you care about. And kind of play it out in your head, practice it in your head. And it may sound different for a family member than it does for your friend down the street. So certainly that's the next step, is asking the question. For those that say, Gary, thank you, yes, I am miserable. I don't want to go on anymore. It's just been one miserable life event after another, and I can't seem to get a way out of it. Then you have the opportunity to, you don't have to be the therapist, but let me help you get connected to a place that can maybe assess where you are, work up a treatment plan, put some things in place that will help move you from where you're feeling right now. You're feeling very stuck. So that's part of just equipping people with, just as we all were supposed to know how to do cardiopulmonary resuscitation because we could all save a life. That's the same concept behind QPR, question, persuade, refer. Is that we have a common understanding of what to listen for, look for, situational awareness, and not be afraid to actually utter the word suicide.
Now, if a patient is referred to Ridgeview, and maybe entered as a patient, or you do inpatient and outpatient, right?
We do.
So whichever they become your patient, how do you help a person with suicidal tendencies?
So one of the first things they receive, there are several different tools out there, but there's a very rigorous suicidality assessment. So we know suicide's on a continuum. It's not like yay or nay. There are degrees of contemplation. So that's the first step, is they get that rigorous assessment. It's the Columbia Suicide Rating Scale. I mean, if you can Google it and it'll pop up. A very standardized evidence-based tool. Now, depending on the results of that, it could lead to an admission into the hospital, which is typically about 4 to 5 days. It's intended to be short-term, acute stabilization, and then hook you up with the resources to better manage how you're feeling in the community. It may be referring you to outpatient therapy. It may be medication management, so a psychiatric evaluation from a psychiatrist, where medication may help how you're feeling. And then there's a whole host of other wraparound resources that may be more community-based. Everything from supervised residential, maybe you need substance use disorder treatment, you're dealing with some addiction issues,
Okay.
Maybe it's a relationship issue, and what you need is some marital therapy. Maybe you've lost a loved one recently, and what you need is some grief and loss therapy.
Right.
So the constellation of options are really many and varied,
Right.
but it all begins with a very good assessment.
Right. That's great. All right. One more thing, then I'm going to open this up a little bit. But if you are out there listening to this video, and you say, I am feeling this way, I definitely need some help, what should that person do?
Yeah, excellent. Yeah, so folks may now beginning to hear that there's a new emergency number. So for years, it's been 911 for a medical emergency.
Okay.
So nationally, they're beginning to roll out and introduce 988.
Okay.
So if you're experiencing a psychiatric emergency, you can call 988.
Okay.
And now it's a national sort of pipeline that will end up routing you to an appropriate location. Or if you live in any of our coverage areas, Anderson, Roane, Scott, Campbell, Morgan County, Ridgeview is the mobile crisis team provider. It's a 24/7 emergency assessment, so emergency crisis line that you can call. It's on our website. For Knoxville and some of the other surrounding counties, I believe Helen Ross McNabb Center is the they provide that service in this area. Those numbers, you can also, people could, if someone were to just Google feeling suicidal, I imagine the Tennessee emergency number is going to come up, the red line number, the statewide suicide prevention number is going to come up. All those would be tools and resources that could ultimately connect you with a provider in your area.
Okay, right. What am I not thinking to ask about this?
I think I always think about getting earlier upstream. I know feeling suicide, right now suicidal prevention is the topic, but the act of suicide, most of the time, not all the time, most of the time is a highly impulsive act. Now people may think about it for a long time, people may develop well-orchestrated plans. But close to 30% of all suicides have a blood toxicology alcohol level. So, I remember what alcohol served for me in my younger days, and it was a inhibitor. It inhibited addressed my inhibition, whether it was to walk up to that girl or whatever. And so we know people are, there's a high proportion of folks that are acting just on that impulse. And that we want to, what is leading, has led to them being at that point? Can we get further upstream? And that begins with, we have to be doing this kind of stuff, mental health awareness. People need to be not just considering how they're physically feeling, but how they're mentally feeling and doing. And that there are more people dealing with anxiety and depression. If left untreated, if left unaddressed, those things can lead to feeling like tomorrow is not worth living for. So,
you see there's still a stigma in the country about against getting mental health.
Oh yeah.
There's still a lot of people think it's weak or whatever.
I mean, I think we've come a long way. I mean, our local papers now run, opinions and articles around the importance. After what happened with Naomi Judd, there was an outpouring of mental health awareness.
Right.
So the needle has moved.
Right.
But to say that the funding for mental health is on par with the funding for diabetes, cardiovascular disease, gastrointestinal.
Be careful, you're hitting the coast of home here.
I mean, it's just not.
You went through my whole portfolio, all of it. You forgot glaucoma. Will you throw that in? Now I'm good.
Yeah. So, I mean, we've got to get more funding into treating mental health. Where people get mental health checkups.
Right.
Just like they get physical health checkups.
Wouldn't that be great?
Yeah.
That would be great.
Yeah.
I bet no one wants to talk about that in politics, but that would be wonderful.
I will say that to the credit of the primary care community, I don't know if you found this, but the last I go in every year for my annual, now that I'm AARP qualified.
Yeah, believe me, I'm there. I know. Yeah.
And she does ask.
Yeah.
Every time. Have you felt depressed or sad for an extended period of time since the last time I saw you?
Right.
I was never asked that before, so that's a good. All right. So the needle's moving.
Right. I have had one doctor do that. And you know it was here. It was a wonderful experience and very helpful. It opened up a dialogue that we could talk about some things. So I hope more doctors hear this and do it, because I think it can be very helpful.
Yeah.
Be very helpful. I really appreciate what you do. You've meant a lot to my family personally and to a lot of people in this area. And I know it's not just the Michael Yates show, but your hospital, your whatever you refer to, their health services from Ridgeview are helping this community in a big way. Yeah. And I'm grateful that you come on my little show and talk about it, because I think the more people who know that there's hope and there are people out there who really do care, the more we'll keep around, and that's important.
It's a pleasure, and I applaud you once again for elevating this topic during in your show during this month, which is what we're supposed to be doing.
That's right.
And so, kudos to you, and keep spreading the good news.
I will, and I appreciate you being here. Go ahead, mark us down next year. I'll have you back.
All right,
we'll talk about eating disorders, and you can laugh at me. Will that be good? I do not have an eating disorder. Stop. I just eat, and I love it. I don't care. It makes me feel loved. But anyway, I'm just kidding. We're done with it. Thank you so much for joining us. I hope you learned something from this. I think Mike was always very educational and inspiring when he comes here. So I really do appreciate you being here for the show. If you have a concern about how you're feeling and you want some help, please do some of the things he mentioned. Reach out for help. There are a lot of people out there that want you to do well. So please get the help you need. Thank you for watching the show. Please remember, we are trying to do some good in the world. Please help us spread these shows. Let your friends know about it. Let your enemies know about it. Spread it around. Put it on social media. Whatever you can do to help spread it. Thank you for being here, and we'll see you next time. Good night.